morning, everyone. Thank you all for being here. We can see you somewhat. We've got a great panel here today. We're very proud of this panel. We're all catching up and seeing all the different connections that we have, so I'm just really excited. Again, my name is Joel Myhre, and I've been a consultant with the United Nations, connecting Silicon Valley to Geneva and other places for a long time. But with no further ado, we're going to go through about 30 minutes of talking about all the great work being done by our team members here, and then we're going to also segue to 10 minutes of questions. Thank you all for being here. Again, we're going to start off with Mrs. Huguette Diakabana, the founder and the deputy director of the African Alliance of Digital Health Networks. And she's going to give an overview of what she's doing, and then we'll work down the panel to hear about all the good work and all the synergies that we have. Over to you.
Thank you. The African Alliance of Digital Health Networks, we are essentially a mega network of regional networks that includes policymakers, clinicians, project managers, community health workers, and individuals who are working to contribute to the technology and public health space. And the objective of the network is to ensure that people have an awareness of what's already available and make the link to how it could help solve some of the problems they're trying to solve. And so that's the core of our work, ensure that people have a say in the solutions that are being applied and developed.
Thank you, Huguette. And we were saying that backstage, that one thing we're seeing here and with all of you, we all love technology here. We're all kind of geeks at heart. Some of us are practitioners. That's why we love this panel. We're pairing great technologists with those who create technologies. And how do you make the best solutions? Well, we always said you start with people and with networks, and that's why it was so appropriate to lead off with what you're doing. Next on the panel, Komarneni, the founder and the chair of the Human Diagnosis Project. And I will say, I'm so excited because I've downloaded your app. I also want to make sure that folks in the audience, I want this to be interactive. When I've been able to teach in different places in California and elsewhere, I know you're often looking at your phone. I'd like you to look at these cool apps. Again, so over to Jay, who I know has been traveling a lot, to give an overview of his great work.
Yeah, it's great to be here. Thanks, everyone. So the Human Diagnosis Project is an open AI system for global health. And basically, if you think about Wikipedia or Linux as an open encyclopedia or open operating system, our goal is to bring the same to medical intelligence. And really the reason we think this is so important is technologies have a tremendous power to either exacerbate or close income and wealth and health disparities. And artificial intelligence is perhaps the most promising invention of our time, and if we use it properly, we'll be able to dramatically provide significantly better quality care and access for patients all over the world. So half the world, as we know, has no access to essential health services, and really the only way we're going to do that is by equipping existing health workers to do more with less, as well as to train more health workers. And the primary use case of the Human Diagnosis Project today is actually as a training and teaching system to ultimately enable different physicians around the world to create and solve clinical cases with each other. And as they are creating and solving clinical cases with each other, they are building this open system for every physician around the world.
That's fantastic. And again, we also, what we were saying about all of us having these different connections and how we want to make sure that not only we're going to talk about amazing things and get your feedback, but we want these relationships to continue. So when we're not on stage, we can actually see you because it's quite bright. We want you to connect virtually, personally, to use this app. Also, we know we've got so many clinicians here that can evaluate this app, ClickMedix, which we'll hear about as well. But the technicians and those that are technical and doing data, they can look at it and say, hey, maybe you want to make this better. And I'm also cognizant there may be folks in the audience that are looking for work and doing great innovation. And of course, I was hearing about all of the great locations where Jay is working. So thank you for being here.
Thank you.
With no further ado, over to Dr. Ian Norton, a great colleague who I was so fortunate to work with during the Ebola outbreak of 2014-2015. He's leading, again, the emergency medical team effort at WHO and has a vast amount of experience from Australia throughout the world. Welcome, Ian. Thank you.
Thanks, Joel. So in brief, my role in WHO is to support the professionalization and raise the standards of clinical care response teams that respond to emergencies, disasters, and outbreaks around the world. So part of the work is building on what we saw in Haiti. Haiti was really the start of this within WHO, where we had lots of clinical outpouring of goodwill, people watching BBC, CNN, etc., thinking they had to do something good and running in But unfortunately, arriving in Tahiti and realizing, I have no idea. I didn't know they speak Creole here, or that it's quite insecure at the best of times, never mind after an earthquake. They didn't bring the right drugs and the right equipment. And unfortunately, some were not actually medical practitioners, but said they were. And we think up to 50% of the amputations that occurred were not medically required. We had to do something about it. And this is really the catch cry here is good intentions are not enough. They all had good intentions, but we had to set some minimum standards. And so from that has built what has become really a global phenomenon. Grassroots up now, each country has two major tasks: to develop strong national clinical teams they can respond quickly to an event, be that a landslide, an earthquake, or an outbreak. And then also quickly identify good quality teams around the world and invite them in, but under their coordination. So it's really localization at its best. Strong national teams that will be in the best position to save lives quickly and culturally and language appropriate. And then good quality international teams coming in that reach a minimum set standard and in a coordinated way.
That's amazing. Well, welcome.
Thanks.
Ian, I know you're gathering no moss and flying here and there, so we're really glad to have you on stage. Again, with no further ado, we're so lucky to have a representative from UNICEF and their amazing innovation team, which frankly, and I think you all get this, beware of words, big data, it could be AI, it could be this, but what's really happening? And we're learning about how AI is really saving lives, and also what is real innovation. And the folks at UNICEF, Chris Fabian, his team, and Clara, again, from your lessons learned from CERN and elsewhere, we're really excited to hear more about your work, and thank you for being here.
Thank you, Joel. We are happy to be here. So yeah, I work in the Office of Innovation of UNICEF. It's a small group that we work across different divisions and also with our country offices. So we don't specialize in health, but we also work with education, nutrition, and all the others. And my team in particular, we focus on a product that we call Magic Box, and it's basically a platform to use big data for UNICEF and machine learning. So we partner a lot with private sector for data sharing, but also for expertise. And then we partner with academia, who are the experts in, for example, disease modeling or other kind of uses that we can leverage the platform for. And then we have several country offices in the world that are testing and, of course, working with the governments to be able to make decisions out of that data.
That's fantastic. It's a great overview, and we're going to go finish up here and kind of walk down through and find out about lessons learned on specific projects. I've been able to work with satellite imaging and other tools, and I'm so excited that you're also in that space.
Correct.
So thank you, Clara, for being here.
Sure.
And of course, not last but not least, but also giving us great insights on her amazing app. I was reading about it this morning. Imagine if, in the idea of mobile health and e-health, that you could actually connect 1 billion people with an app. And I'm a geographer and a map maker, and beware of people that are geographers and map makers, because geography sometimes makes inequities. And your idea that you could connect that many people, and irregardless of where they are, where they're from, what language. Again, ClickMedix is a great app. Please download it. I did this morning. Ting, Shih, thank you for being here. Over to you.
Thank you, Joe, and thank you for having me. So the idea for ClickMedix is born out of MIT with the audacious mission of improving the health of over 1 billion people. And when we thought of a problem that big, it's really about how do we extend the expertise of doctors globally to frontline workers that are nurses and health workers. And when we started with cervical cancer in Botswana. And we worked with the women's health expert to understand what are the questions she needs to have answered in order so that she can look at the information about the patient and make a diagnosis on whether there is cervical cancer or not. And we taught the nurses who are working at the HIV clinics who are receiving these women to screen for cervical cancer, asking them for their HIV status, their family history of cervical cancer, and then a visual examination of the cervix after applying acetic acid, which is really household vinegar, and taking a picture of that. And after going back and forth, here's a picture. Does it have cancer or not? If it has cancer, treat it. They're learning to make that diagnosis on their own. And then we've extended it to other diseases, TB, HIV, and chronic diseases, diabetes, hypertension. And now at volume with machine learning, we can actually start to make predictions before the patients have those diseases, particularly in chronic diseases. And then teaching the frontline workers to screen for those issues with the application, with the screening questionnaire, and then confirmed by experts that are available globally.
That's fantastic. And again, what can I say about this panel? We were, again, talking about, last week and earlier today. I think there's a lot of synergies here. Also, I think we're all just impressing each other with all the things we can do and all the things we'd like to do. And that's a good lead into, you're doing certain things now, but I kind of want to give, what are your thoughts for some future projects or ideas, things that you've thought about that you might have seen over the course of the last couple days, or in your work? I know, Ian, when you're going somewhere and you're like, boy, I wish I could do this, because this is really as they say, we've got folks that are connected, to not only X Prize and other things, that idea of a moonshot technology, not just growth like this, but exponential growth or exponential medicine. What are your thoughts, Huguette? Any thoughts on that?
So this has been really exciting for me. One thing I should mention, make a plug for this, we were able to bring 5 fellows. So we have a fellowship program as well as a entrepreneurship program, and we launched our fellowship program starting slowly, but it's already really exciting for us. So we have 5 fellows from 5 different countries who are here. Each of them are working on, in some way, to provide technical support, either as a Ministry of Health employee or as a partner providing technical support. And they want to be able to capacitate ministries so that they use data as well as available technologies to improve access to services and then quality of services provided. So why they're here is because we wanted them to know what's possible, what's being planned. And so my dream really is, for myself as well as for our fellows who are here, as we walk away, they know they've met these people, they know we're now connected, and they can bring that back with them and let the ministries know. And also the colleagues in other countries who weren't able, we had 97 people apply for the fellowship, but we could only afford to bring 5. So we're going to ensure that those 97 people are connected with companies that are working with resources, with those who are working on policies, and figure out how they can, in some shape or form, whether it's simply by discussing ideas or really developing actual projects in collaboration with the colleagues we meet here, and start bringing some of what is available within our country. So that's really where we see, and the idea is to have the 2 worlds, those who are developing solutions and those with the problems, constantly connected, constantly talking, and constantly sharing ideas so that the developers develop targeted solutions that are addressing specific problems. And then those with the problems they're not afraid to dream of a solution that's really going to eliminate a problem that they have. So that's kind of our big dream.
Well, what can I say? I don't know about all of you. Doesn't that make you excited about the potential? And again, that you led right into a question that I had, is about, we're all doing great work, but about capacity building, and you're so good at that. And over to you, Jay, for your thoughts on it. I know you've got a growing team, you're in various geographies, you work all over the world. What's your thoughts on kind of that idea of kind of the long tail for what you do and building that capacity? Because you've been in so many different incarnations. I mean, it's amazing to learn from all of you.
Yeah, I think to your earlier question about what is a true moonshot, today we have disparate data sources all over the world in silos that can't talk to each other. And the primary reason that is, part of it is actually the structure and political will and interest in sharing information. So one big challenge that needs to be solved is using techniques like differential privacy to actually enable people to share their information without the concern of that information being exposed in an underlying way that can still be used to train models at scale. The second area really is that these data sets cannot talk to each other. They don't have a common structure or language model to be able to be processed relative to one another. And part of the reason that is because the way that medical ontologies are created, so for example, the International Classification of Diseases or Unified Medical Language System, is they're rolled out periodically in these very large waves over years or decades. This is very similar to the way that Encyclopedia Britannica was published every several years instead of Wikipedia. So what we really need at the heart of global health is a self-evolving ontology that is changing as a function of physician and health workers' inputs from around the world, because then that ontology would actually be able to read information in many disparate silos and data sets and be able to coalesce or synthesize that insight into a singular approach and system that could help many different stakeholders.
Jay, that's, again, coming from the data side and interoperability and all the challenges I know Clara has dealt with as well. Thank you for that message, and we'd love to collaborate on that side. And of course, I know you're going to be in Geneva tomorrow, so thank you for carrying that flag. So from the people to the data, again, to the strategic systems that I know Ian is building. Ian, what are some of your kind of think out of the box thoughts, those challenges when you were there dealing with the floods in Pakistan or Haiyan and other things? Because I know when we first met during Ebola, you were talking about having 1,000 patients lining up outside the clinic. What would help scale that? I know we learned a lot yesterday from some people doing that. What are your thoughts?
Thanks, Joel. Well, yeah, maybe people were asking why on earth is that guy the guy they send out to the field to places everybody's running away from. What's he doing on a panel and he has no idea about AI? Well, I'm here to sort of give you some impression of what we could use because a lot of this is centralizing data, or some of the bigger systems that are centralized, and we're looking for flexible, evolving data in real time that can be used to take a line call 50-50 and make it 60-40 and let us go. That's what I want. I need something that takes incomplete data sets. Nothing is sure out there. The earth is just shaken and everybody's lying in the street. It's a chaotic situation. You just need to help us, if you can, make that chaos slightly more. I don't want 95% and confidence intervals. I need a 50-50 to become 60-40 and we're off. Because when we press the button for some of these big teams, we're talking about $1 million a month to bring them in one place. And in Nepal, we had 142 teams. It's huge. And when we press the button, it has to be with no regret because it was to save lives or relieve suffering or stop an outbreak. I need to cap it with, and then these teams now with the new standards are sending us huge amounts of data. They have all agreed and signed that they will survey what they see on the ground, and if they see a bloody diarrhea or a paralysis in a kid, they'll instantly send it in. But if we don't have something to absorb all that huge new data that's coming in, this is new ground. Now these guys are reaching a standard, they're coming quick, we need to know where to send them, and then they'll send us data back, but I need a way to coalesce it, and then I'm not going to be interested in data that doesn't make a difference tomorrow. I'm afraid. I'm an emergency physician, so I'm like a goldfish. Every time I go around the bowl, it's interesting again. It has to be because I work in ED, but no, we need something that's going to make a difference operationally tomorrow. And if I can, for just a moment, bring you back to Ebola 2014, and I could not find anybody to tell me where this disease was going to make it 60-40, and I had an interior minister for health, one of the 3 countries, telling me his plan was to put up camps, put the infected in one, and deliver food and water, and then bring their families forcibly with the army into the other camps. And we have to do something about this, which was to build treatment centers. So I said, right, Liberia, we need 17. Here, 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 and here. And everybody went crazy. You've got no epidemiology proof. I know where the roads go. I know where the population is. And if I was a patient, I'd know how far I could walk. So we had to distribute the teams. But we need to do better. Thanks.
Like I said, I'm always, and as we're building these friendships and relationships here, and that's really the whole point. In fact, we were talking earlier about Huguette's family, who are in DRC doing great work, and how we're going to all continue this. Tomorrow is when it really begins. Those lessons learned are important, and again, I think we've got, again, having Dr. Morgan kick it off this morning with such keen insights. He's got such a great team. We've come so far since Haiti was the beginning of what we call crisis mapping, and I was involved with that as well. It was right on the tail of H1N1. And as you said, Nepal, how do we do exactly what you spoke about is what we need to do. So for those that may be working with the UN, or maybe if you want to volunteer, there's plenty of ways to do that, because so many technologists here, if we can pair you with these practitioners, of course, I know that leads right into what UNICEF and the innovation team does there. So Clara, any thoughts on not only your great projects now, but other ones coming down the pike to kind of whet our appetite? So.
Yeah, I think for us, 2 main applications that are related to health where we can use AI. One is indeed to enhance the epidemiological models so that we can forecast maybe where the disease are going. And of course, we know that one factor of the disease is how people are moving, right? So people movement transmit diseases. So now with big data, we have the opportunity to use movements in real time. Like this morning, we were seeing plane flights. So we have partnerships with Amadeus that manages 60% of the global flights. We have information in real time about that, and also with mobile operators. So if we can input that into the existing knowledge really from long time ago on epidemic modeling, probably we can increase and have a more real-time view of the situation. And then the second point, it's about satellite imagery, like you were saying. So really trying to see, many times we plan things on interventions in areas where we are not there, right? We cannot be everywhere. And what if we could use photographs? And of course now we can, because there is plenty of companies photographing the Earth every day. So we could have information with high resolution photographs of areas where we cannot reach, maybe. And with deep learning, there is a lot of progress on how we can detect automatically extract features. So we, for example, are doing a project with WFP on crop mapping. We have done also school mapping, so detecting where are schools, so that we can either validate the data that we have or also detecting areas where maybe we cannot survive so often. Yeah, so I think that these two technologies or these two areas could be really change or at least contribute to the health section.
That's amazing. And again, we're just such fans of what you're doing. And I see some synergies from not only the networks that exist to the new technology, and again, over to Ting and your work with, what are your thoughts on new innovations on your platform? Of course, I was even thinking during the last Ebola outbreak, not only UNICEF Innovator is great, but UN Global Pulse is great. And they were doing work with call data records, which are anonymized. If all of you have cell phones, presumably, or 2 or 3, if you're in the disaster business, you often have many. And if you walk across the street, you may hit a different cell tower. Now, if there's a fire here and 100 of us walk across the street, that tower doesn't show anything about your calls or anything else.
Correct.
But we were experimenting with that, but I also say I'm from the United States, and a lot of the money flows through Washington, D.C., and we always say that it takes lawyers, guns, and money to make stuff happen. So we'd like all this technology to integrate, but this will lead into what we'll talk about next, which is privacy and other issues. But in terms of innovation, I think, what are your thoughts on where you could go with your platform, and also how you could maybe integrate with these great, maybe a B2B or a business to UN type project?
Yeah, and I think what we all know now, there is no shortage of data. But how do you make that data actionable? Taking all the data, what's happening, where should things go? How do you shift from the 50-50 flip of the coin guess to here's the better decision than that? We're not looking for 100% accuracy. And we've designed the system in terms of diagnosis and teaching the frontline workers to make that, to be the hands and eyes of doctors, to be the doctors where there are none. We worked with specialists to figure out, well, what is it that you see? For example, Sub-Saharan Africa, you're most likely dealing with some HIV, some TB, some multi-drug resistant. That's going to be, say, India, Pakistan. Their disease levels are going to be different. People on the ground knows, okay, you need to ask, is it HIV plus multi-drug resistant, or is it something else? The experts on the ground really know. We've designed our system on the back end so that a clinician can actually create that questionnaire and add these tokens of knowledge that they only know on the ground and share it broadly. And I think partly it is working together, and all of the innovators would know how hard it is to work with likes of UN. The process is long and convoluted. I mean, I'm from DC, and necessarily so, it's just a long innovation process. And I think unless we start doing something more than workshops and conferences and making it actionable, connecting innovators and problems, and there's a lot of activities going on, it would be difficult to solve the problems where technologies already exist today to solve the problems that we all have.
No, that's great feedback. And again, what's also neat is the geography is covered by this amazing group. And so we'll have these further conversations. As we go into this, the last part of our panel here, I'm also going to make a pitch that, like I said, as we go forward, we have our colleagues from the ITU here, also WHO, and we are going to be having a working group. So we can every quarter meet and talk about AI for health, and that's going to be kicking off here at the end of September in Geneva, also looking at further meetings in China and elsewhere, and of course, Sub-Saharan Africa. Let's keep this work going. So that's my little call to arms, that we want to keep doing this. But now back to, we'd all like it all be perfect and to all integrate. But what about some of the issues you've encountered that didn't go so well, whether it was a collaborative issue or a data privacy issue? Just a few comments, and we've got about 5 minutes left. So any thoughts?
So quickly, with the data privacy issue, there's still a trust issue in terms of, as as we hear, there is no shortage of data. So because we've normalized using digital tools to collect data, we have a ton of really awesome data sets that we are not necessarily able to use. And so we are at the African Alliance, we're prioritizing building trust with the governments. We started this organization with the blessing of 5 ministers of health from 5 countries, and they agreed that there is a need. So I'll put it out there. Use our networks to be the bridge if you need assistance with building trust. The work you're doing is amazing, but if you're not trusted to use the information to do your work, then it makes it quite impossible. And so that's one of the areas where we see policies haven't caught up with the technology, so there's still a bit of a challenge in trusting people with their data.
That is so important. That idea of trust is key. Jay, over to you on thoughts, and thank you.
Yeah, so I think the common theme is really synthesis and emerging insight quickly from existing data sets. And there's really a couple things that need to happen for that to be able to occur. So number one is offline and low internet capabilities is extremely important in these settings because it's very unreliable. So actually posting and getting data in such systems is incredibly important. So things like mesh networking and others can actually help improve that. The second is, in many of these contexts, health workers are not literate. They speak different languages, so you need to be able to support multiple languages. You need to be able to support user interfaces that don't rely on the ability to read. Number 3, you need to be able to learn on disparate data sets without sharing private information. So the example I gave of differential privacy, where you can actually introduce noise into data sets so that you can't track back where that data actually came from. And then number 4 is the point that I mentioned earlier, is if we don't have a common language model or ontology for these different data sets that are talking to each other, we can't synthesize information between disparate human and machine agents. So we actually have to be able to have a common language model to take the disparate inputs of those human and machine agents and combine them into a singular answer.
Oh, that's fantastic. Over to you, Ian.
Thanks. I would reiterate quite a lot of what Jay has said. From our side, as a practical example of this, we had several different groups wanting to push a particular platform to answer this minimum data set, what we should ask these teams to feed in. And we said, it's not about, we have to be platform agnostic. We have to make sure they all talk to each other because the world is 195 countries. It's going to be different everywhere. The one resounding thing that we've come out with, though, is that localization is the key, not centralization. It's going to be very difficult. And the trust issue for local actors, we have to somehow work a system. And maybe Liberia, the incident management system of that country during Ebola is a good one. We didn't displace the ministry. We supported CDC, WHO, all the others were there as partners supporting them, and therefore they trusted us, and the data was easy to share in that phenomenon. And afterwards, we leave them in a stronger position. If we build it over here, we weaken them, and they don't share their data with us.
That's a great way of this idea of a catalyst. Great example. And again, over to you.
Yeah, I agree basically with what has been said. And building on top of it, I think that there is, of course, a lot of data, but probably not from everywhere. So I think that there is a lot of bias as well, that we need, data science and data research to be able to ensure that the decisions are correct, no? And that we read the data as it should be read, and that we don't leave behind those that are not in the data, which happens sometimes. And that's why in UNICEF we're investing quite a lot on data science capacity itself. And then another challenge is on sharing private sector data, that now it's like data is the new oil, and there is a lot of protection, of course, about sharing it and all of the new privacy rules and so on. And that is, of course, a challenge that we are working closely, trying to work closely with the private sector as well as with regulators or entities like the GSMA or like the groups in AI for Good. I think that all of that can help that it's smoother in the future. Those have been more challenges that we've had until now.
That's great. Well, again, you've done so much homework on governance and everything, so I think that's what's great, how the UN can also learn from each other, because it is a big animal. It does a lot of things, important work, but how do you build off other people's successes? So thank you all for that. And think for your thoughts, we have a minute left, but some thoughts on privacy and challenges, and over to you.
Sure. So we work across 20 countries, and certainly all the screening information actually starts with patient signing a consent form. We treat the patient we started as a telemedicine platform. So a patient essentially is a patient that eventually goes into a health system, clinics or hospital with doctors reviewing their information that were transmitted remotely. So by the nature of what we started doing, we have to protect the data every step of the way. Some of the challenges working across 20 countries, some countries require the data not leave the country. So then we do on-site install so that all the data are there, but the data structure are in the sense that where we could extract it at a higher level and look across globally what are some commonality or learnings that we're seeing. And I think at the same time, what are the global expertise that can be added to some of the screening and diagnosis and also treatment recommendations.
That is fantastic. Well, again, I don't know about you, but I've learned so much. Just again, we've had this half an hour, and what an amazing group. And we're going to open it up for questions because we really believe this dialogue, which will go for 10 minutes, but it's going to continue after, is going to be great. And so thank you all. And again, over to you to any questions from the audience. We can't see you that well, but lift your hand, and we'll try to feel it out there. So over to you. Okay. But I think there may be some microphones coming around as well. If you want to stretch your legs, stand up. Okay. There's a gentleman over here I can see, and a gentleman here as well.
Well, this is actually kind of a challenge because I've been thinking a lot about what happened over the last yesterday and the accuracy of information using data real-time, aiding, for example, in a hospital in Portugal where they have live information helping patients right now. And my friend Myhre from XPRIZE reminded me of the difference between good data and bad data this morning. And I was contemplating the whole time the concept of artificial intelligence itself, which sounds a little bit like fake news to me. So I thought, is there a better word we could use? Because it's kind of dramatic these days. And we installed an artificially intelligent system in the White House 2 years ago. It's got mostly bad data. The algorithm seems to not be functioning well. And so I thought maybe we should change that to advanced intelligence or something like that, because everybody, including the regulatory system and the insurance companies, need to know that the confidence intervals are high. And of course, for emergency responders, we have to get through as much noise as possible. So comments from the panel?
There's a term I like, which is integrated intelligence. So integrating the intelligence of humans and machines, many around the world, collectively to solve problems more effectively.
Actually, it's because they already reserved .ai, and we might be stuck with A. I don't know, because there's amplified, accurate, something.
Augmented, yeah.
Everybody's already got their domain names.
Thank you.
A quick story about this, because we have the opportunity or challenge of translating artificial intelligence to but in Africa it's primarily French or Portuguese, but also in local languages, Swahili or Lingala or Myhre. And anytime you translate artificial, it does sound fake. And so it's always a challenge to be taken seriously, to go to a ministry and say, oh, this is something that will help you advance or enhance, but it's artificial. So I do agree. I will leave the question out to the innovators. That is a worthwhile endeavor, I would say.
Any other comments from the panel? Or? No. Thank you. Great examples and great question. I think we had another question in the back. Thank you.
Hi. I'm just curious about the point that Ting made on engaging with the organizations. Obviously, there's a lot of focus on the exciting stuff, which is the tech, the data. But if you're going to engage with the private sector, who are often better placed than certain organizations to provide the support, the information, the insight that you guys need, or the organizations need, how do you improve the efficiencies in those relationships so that by the time you actually got that partnership, that things haven't moved on so far, that it's not as effective as it could be, and focus on making it easier to work together?
Well, I'm not sure if I understood. The question is on timing, like on...
So Ting made the point about the process with engagement between organizations and private sectors can be lengthy, it can be difficult. So how do you improve, how do you share some of the focus on progress and not commit everything to AI, data, tech, and the exciting stuff, and actually also the focus on the practical elements of progress?
Well, from my experience, that is what private companies want to do, right? So it's always about where are you using this? So we have, like, you need to balance a little bit, because I cannot go to like whatever Kenya and say, oh, would you like to use this data and these models without having the data? And then I can also not get the data until I have a user that really wants to use it. So I think it's indeed this length. It's been long. And this is why we try to build the partnerships before the emergency. Like, we really think that the most value is during an emergency because of the real-time need, but we try to build the partnerships in advance so that we can be in agreement of what we want to do, and then if an emergency strikes, then we have already that agreement built and the system connected, because then there is all of the challenge, like you were saying, on how to connect the two systems, because many times we don't have the same formats, or we don't have the same infrastructure.
That's a great question. Ian, for some thoughts on
Yeah. I mean, obviously, we're another of those agencies that it takes a long time, and clearly, industry moves much faster than we do. I think we should use our comparative advantages. There are certain parts of our house now thinking more collaboratively with private. WFP and other parts of the UN do, I think, this much better, and we need to do better. I think maybe best to maybe talk offline, but also give you one short example from the Pacific happening right now. I won't name the company or the thing. It is actually funded by a donor, but it is a private group. They're using data to map and picture and formulate pharmacy delivery services across the very remote Pacific Islands. What we've done on my side from emergency response is now, because we have a footprint run by a private company, which the ministry have embedded and used day to day. Now, that's the first key. If they like it and they use it and they pay for it, great. And on top of that, then we've layered, it's just a mapping layer, but that now can be used for disaster management, because now we've known where every clinic is, we know what they were before, we know their stock. The moment the cyclone hits, we can also use the same platform for the emergency response. And that's the kind of meshing I was looking for.
No, that's a great example. Any other comments from the panel? Or again, great examples. We're learning as we go here, and the questions are great. I think we have time for one more quick question from the audience. I can't see if there's any other. Oh, thank you.
Hi, thank you very much for the inspiring talk. So I work on biosensor. So my question is it one priority for you to develop more intelligent diagnostic devices, or the current technique in your mind has already satisfied the need? Thank you very much.
Thank you.
I would like to respond to that question with respect to biosensors, but just data systems in general. So the functional problem is that the data we capture today is not deliberate in the way that it's organized, the way that it's structured, the way that it reduces signal to noise. And that's true of whether we're dealing with capturing data in a public health registry or an electronic health record or a biosensor. So in short, no. I think the deliberate focus of creating information and data that can ultimately solve challenging public health problems, we're at the very beginnings of that. And in fact, the biggest blind spot that all organizations have that are focused on AI today is they're focused on using AI to interpret data which already exists, that was captured for a completely different purpose than solving or interrogating the problems that they're trying to solve. So the key is really to actually develop and organize such systems in order to actually capture and solve and answer the questions that you're interested in.
And to just also add on to that, I think as we look at who's actually capturing the data, at times it's going to be patients themselves. It's going to be your frontline person who has no medical expertise, very little literacy. And to the extent that a biosensor can be so easy to use that the user probably just need to put it on or press a button, that's tremendously helpful. But to your point, from a clinician side, it needs to be then actionable. And I think that's where the machine comes in, interpret the data, get rid of the noise, and actually interpret and say, here's when someone needs to look at the data and do something about it.
That's fantastic. And with that, we've got such great insights. Just those last two comments, we're going to be thinking about those. And I want to thank the panel. What an amazing panel. And we're all good friends. We're going to be becoming more friends as we go forward and look at ways we can collaborate. So thank you all for the great questions. And thank you, panel.
Thank you.
Thank you.